And help yourself to food and beverages on the table, and when it's gone, it's gone. Let's bow our heads to pray. In the name of the Father, and of the Son, and of the Holy Spirit. Amen. In gratitude, dear Lord, for the time and knowledge of this physician, Brian Unwin, and parishioner, to address a much-needed topic for those of us over 60. Normal aging versus dementia. In your name we pray. Amen. Brian is a physician, a professor of medicine, community, and family at the Virginia Tech Carilion School of Medicine, residency and fellowship in family medicine and geriatrics, and also a section chief for geriatrics and palliative medicine. You do it all.
Thanks.
Do you need the mic?
Yeah. Can you all hear me?
Oh, yeah.
So we'll talk about your hearing in a moment, too. So the talk today is about what I was asked to talk about is differentiating what is normal aging. Am I normal? Or am I getting into trouble? Am I developing dementia? And that's where I want to kind of focus today. The slides will be about 30 minutes because I find that on public, speeches and things like this, you have a lot of questions. And so we'll try to shoot for about 30 minutes of questions to kind of help you navigate these waters. I want to start with this slide first. And between surveys of older adults, and I think if we look at ourselves and an honest look at the way we want to lead our lives in late life, we want to age in place. Who's heard that term before? I want to be in my house until I'm good and ready to, feet first kind of thing. And we get trapped in that we become medically focused. And we think the only way to age in place is by visiting the doctor's office. And I would disagree with that. It requires medical care and medical planning, but it requires attention to these other things to allow you to accomplish that goal of what you want to age in place. You have to have a house that allows you to live in it when you are having difficulty walking, or your arthritis will not let you get up the stairs, or you have been bedbound because of a stroke and your bedroom's upstairs and you can't get up there. Your house has to be adapted to you so that you can get what you want to age in your home. You need that health and wellness thing, but you also need to plan your financial future. And let's face it, and I'm kind of known for being plain spoken. Medicare will pay for some things, but it does not pay for the things that you often need, such as things like aides, and people in your home, and people helping you with your medicines when you can't manage it yourself, or driving to the doctor's office. That basic care, Medicare does not pay for. Medicaid does. And that means you have become financially constrained, and then you get a medical benefit from Medicaid. You have to do some financial planning, and you have to use your financial resources, usually, to get the care that you want. It requires transportation planning. And I tell everyone, if you came to my clinic for dementia care, I tell every older adult, you will eventually retire from driving. Okay? Back in the 1800s, if you couldn't get on the horse, okay? If you couldn't get on the buggy, well, it's easy to get in a car. And cars become life-threatening, and contrary to what you may think, it is most life-threatening for the driver, the older adult, who gets in the accident and suffers some kind of devastating injury from that car accident. You have to plan. What's plan B if I can't drive anymore? What's plan C if my partner can't drive for me? Okay? It requires social engagement. It requires assistance and help. And speaking for the guys in the room, thank God I'm married, okay? My plan A, if I can't care for myself, plan A is take care of myself. Plan B, Cindy, my wife, will take care of me. And you know she will if you know Cindy. Cindy will take care of me. Plan C, hopefully my children will step up and help me out. But what if I don't have children? Or what if it's my child who's kind of the black sheep? Or is my stepson really the person that's going to be able to care for me? And those are difficult family situations, but that social support is what keeps you in your home also. And depending on what literature and depending on the science and papers you look at, roughly 20% of older Americans are what we call solo seniors, where they do not have someone there with them to assist them in their time of need. So who's going to help you down the road? And developing intergenerational relationships becomes really important, because how many of us are now experiencing our friends of 40 and 50 and 60 and 70 years are passing. And so we need to branch out and have a bigger social pool of people to help us, neighbors and friends and church communities, to help us get through late life. Keys to aging.
Oh.
Hello? Everybody okay?
God bless him.
Okay, that's all right, man. We do too. It's all right, you're among friends. Another thing that I think is really important, and doctors I think have to get better at this, is that in later life, we have our medical conditions that we're dealing with, our hypertension, our cholesterol, our diabetes, our lung disease, our kidney issues, etc. But all of those diseases potentially impact these four things that are, in some ways, the most important things. If a stroke has impaired your mobility and your ability to walk around and take care of yourself, if your hearing impairment or your vision impairment is keeping you in your home, and you're not going to church anymore, or your home's not adapted to help you get in and out of the house. Mobility, how do you live your life and get around? We need to work with that. How can we help you do that? Mentation, how is your mood and how are you thinking? How is your ability to problem solve and navigate the problems of the world in those wonderful Medicare forms and insurance forms and co-pays and all that stuff that we have to deal with? Do we have the mental abilities to manage those complex things? Third thing is medicines. Medicines that we take should be things that help us, and sometimes the medicines we take are things that may be actually not helping us and potentially hurting us if we're not aware, if we're not really communicating with our doctors about how medications may be impacting our health. Things that make you sleepy or relax you or sedate you or dry you up because of your allergies or troubles with diarrhea, all of those medicines potentially can impact your cognition, your thinking and reasoning skills. Medicines can become part of the problem. And what's most important in my view of things is what matters. How do you want to live your life when times get hard? When your health is declining, or you're hearing things that we don't have good cures and good fixes for the problems that you're facing, or you're hearing or feeling this is as good as it gets. And at that time, you have to kind of start discerning, how do I want to live my life, and how and what kinds of life support and treatments do I want to have for my remaining life? What matters becomes most important. Not so much what your hemoglobin A1C is, or what your blood pressure score is, or your ejection fraction on your echocardiogram. Okay, how do you want to live? How can we keep you comfortable? What are your goals? Because I'm going to talk about some population problems, and I'll bet all of you, if you don't raise your hands, because you'll be maybe not surprised, but one of the problems that I see commonly, and I do a lot of work with Adult Protective Services, is the solo senior. And that's the older adult that doesn't have a partner with them, living alone, maybe no children or estranged from children, or the children are on the East Coast and the West Coast, and they're alone. And they're telling their kids, I'm fine, everything's fine, we're fine here, fine, we're fine. But they're living alone, and they're solo. And we're not seeing how they're doing and how they're functioning and performing. And that's roughly 20% of older adults. And if you use different definitions, it can be higher. Okay? The other population are the people that are truly homebound. People that can no longer drive because of vision problems. People that can no longer drive because of their orthopedic problems, or their heart failure, or those things where it simply becomes too hard to go to the doctor's office and get out of the house. And the homebound patient is often in a situation then that the only time they get care is when they get sick. And they go to the emergency room, and they get their care, and they come into the hospital, and they become, in a way, dependent on the hospital and the emergency room for their care. Because our systems of care in our country, we don't do home-based care. This is not the 1900s where the doctor would come to your house. Okay? Those two populations keep me awake at night because they're so vulnerable and they have so many needs. The other big public health problem, and this is where you're not going to like me today. 1 out of every 2 women, 1 out of every 3 men will develop some form of neurodegenerative, some form of brain injury that will impact their mentation, their mood, their mobility, their medications. 1 in 2 women, 1 in 3 men. I'm not saying that everybody gets dementia, but 1 in 2 women will have problems with dementia or Parkinsonism or have stroke that impacts function. Same 3 things for men.
Is that because they live longer than men?
Part of it, mostly it's genetic. Part of it is longevity, but mostly it's genetic and many other what we call social determinants of health. But the primary issue is genetic. So these conditions, these issues impact cognition. And understanding that reality, it's upsetting, but if you know it, and then you can start making plans for it. So much is taken from us as older adults because of health and injury and illness. But our ability to plan, to try to work around those things to have our best possible lives, should not be taken from us. And so that's why I'm emphasizing that very first slide. Plan for the future. It's one of the most important things you can do. Anybody regretting coming here yet? Remember when we used to go bowling on Thursday nights or something? You guys came to the wrong place. Dementia, however, is very common. It is the 6th leading cause of death in older Americans. 6th. It is the only cause of death that's on the rise. One of the things that I commonly get questions about, Doc, I have Alzheimer's disease. Does that mean I have dementia? So let's talk about that. Dementia is an umbrella term that we use to describe the different types of conditions that can impair memory, reasoning, and concentration. So the example is automobile. You know that there are different kinds of cars. There are, you can say SUVs and vans and sedans and trucks, or Ford, Chevy, and Cadillac. There are different kinds of automobiles. There are different kinds of dementia. And Alzheimer's disease is the most common. So when we say dementia, that's what I mean by that, the general term of troubles with memory, reasoning, and concentration. And then the types of dementia, and we'll talk about that in a minute. Another really important thing that is hopefully put on the doctor that you're seeing are that there are many other things that will contribute to troubles with your memory and thinking and concentration. And these are things that need to really be dealt with, because if we're not getting you to stop drinking and your alcoholism is causing you to have memory impairment, the treatment for that is stop drinking, and in many ways you're living with the consequences. If you have untreated sleep apnea and your brain is hungry for oxygen when you're sleeping at night, treat that, because I've got no pill that's going to put oxygen in your brain at night. Okay? We have to manage these conditions, and the brain is the most beautiful and the most fragile of all organs. We've got this very strong, bony case that our brain resides in, but it can be hurt in other ways, like from brain injuries from car accidents, or bicycle accidents, or a fall, or an injury, or a stroke. And the brain is not something that, it doesn't heal well. It adapts and recovers as best as it can. But these other problems, we need to make sure we're addressing these issues, because these are potentially things that can get better and your cognition can get better. But if these are not addressed, things don't change. You and your doctor kind of have to work through that and see what applies. If you're having memory problems, you should look under the hood and see if these things are going on. A tool that I use in clinic is this. It's a piece of paper that has these circles on it. And between my chart review or talking with the patient, talking with the family, I'm crossing off these things. And whatever's left is probably the reason why you've got memory problems. In many ways, the diagnosis of dementia, this problem of a functioning brain, where your brain isn't working the way it used to, is a process of elimination. It's a process of elimination. Treating what you can, understanding what has happened to your brain, and trying to figure out how that is impacting your reasoning and concentration and memory function. Does that make sense? So if you've never had a concussion, didn't get your bell rung in the Army, or playing football or a car accident or anything, not the cause of you having your memory problems. Or you are a vegan and you don't really attend to complete dietary supplements and making sure that your diet is complete and well-rounded, you may have vitamin deficiencies that are contributing to your memory problem. If you've had big strokes, strokes can be a source of dementia. So it's this process of elimination, trying to figure out what are those factors that are at play that may be causing the problems versus nothing else going on. And that may lead us to Alzheimer's disease. Medications. I would ask that all of you, when you go to your doctor's office at your next visit, you actually bring in the brown paper bag or steamer trunk of whatever medicines you take, or medicines that you take occasionally, or I bought this at Kroger, or I heard this from a friend that this might be good for this or that. You bring in your steamer trunk and let the doc, the nurse look at that so we know what medicines you're on, really know what medicines you're on. This picture here is a real picture I took during a house call 9 years ago, and the doctor asked me to do this house call because the patient was having unexplained poor control of her diabetes, and the patient seems very with it and says, yes, doctor, I take my medicines and I don't know why I have my poorly controlled diabetes. 35 pounds of unused medicines, close to $10,000 in unused insulin that was just kind of there in the house. And the big finding was she had dementia. And then when you start making sure her medicines are being given to her and the children are observing the medicines and you're kind of getting things organized, her diabetes was well controlled with simple things. It's just that she was finally getting the medicines that she needed. She wasn't taking the medicines that she was being prescribed. She wasn't a bad person. It's just that her dementia was, her brain was not allowing her to organize and manage her medicines. And sometimes the medicines we give can be kind of scary. And I bet many of you in the room are taking blood thinners. And you've been given the fear of God. Sorry, Father, Monsignor, I'm just, you're kind of given the, blood thinners. Yeah, they're a big deal. Taken appropriately, they prevent stroke, and they prevent heart attack and bad things. But not taken or taken incorrectly, that goes sideways in a hurry. And then there are other medicines. The medicine on the left there called quetiapine, that's an antipsychotic. And we use that for a variety of different conditions, appropriately. And sometimes that can be an unsafe combination. Bring your medicines in, review those medicines, and really let your doctor know what you're taking. All right, how do we detect dementia or Alzheimer's disease? And one of the best resources, if you remember one thing from tonight, Alzheimer's Association, alz.org. It'll tell you everything that I'm talking to you about tonight in many ways, alz.org. And they have published 10 different warning signs, and you can go to the website and see that. It is part of the American Academy of Family Medicine's cognitive care kit that doctors can use to help provide care to patients who are experiencing dementia. And it includes things that memory loss that impacts daily life. Now, this morning, I'll make an example here. Where did I put my keys? Think. Okay, it's in the office. And I go to the office and there are my keys. Did it impact my life? No. Did I have a mental pause there? Yes, I did. Okay. But did it impact my living and my day-to-day work and my ability to function? No, it did not. Our brains will have hiccups. Okay. That's not dementia. Challenges in planning and solving problems. That can manifest in 100 different ways. Managing problems like, do I take 2 pills once a day or 1 pill twice a day? That becomes important. Is this my blood thinner or is this my diabetic medicine? Did I take my diabetes medicine? I don't think so. Maybe I'll take another. Okay? That's becoming impactful. Difficulty completing familiar tasks. I have never been able to balance a checkbook. If I can't do it at 85, can't hold it against me. If my wife can't do that at 85, that's a problem. She's always been able to do that. But completing familiar tasks, including driving, managing the medicines, mowing the yard, cleaning the house, cooking the meal. If those things are becoming a real issue, maybe there's a problem. Confusion with time or place. Now, what day is it today? Well, it's April 2024, and is it the 18th? Yes. Thank you. I have a computer that puts that on my paperwork. Okay? But if I'm thinking that this beautiful spring day is winter, I've got a problem. All right? Trouble understanding visual images and spatial relationships. Kind of hard to describe, but is that the car accident that was kind of unexplained? Turning left against traffic and not gauging the oncoming traffic. Is that the problem with seeing an object or seeing a person and you're my mom? No. Okay? Misidentifying people. Difficulty reading and understanding documents that are pretty kind of self-explanatory. Okay? New problems with words in speaking or writing. This is, again, kind of complicated. Can be manifested in a bunch of different ways. But the writer who is no longer able to write, the person that loves reading books who is no longer reading, the person that loves doing the word searches, and then when you look at the word search book and there are no word searches, no circled words, something's going on, okay? Misplacing things and losing ability to retrace steps. Well, that sometimes happens, okay? But just, where did I put my keys? No, I found my keys. Not a big issue. You found your keys in the freezer? Okay, and you keep doing that? That becomes a concern. A one-off, you put the keys in the freezer because you just had a grandbaby or something happened in the house or there was a fire or something. Yeah, I mean, sometimes we'll just do things that are, I call them misfires. That doesn't reflect a problem. But if it becomes repetitive and it becomes kind of, mom's doing it again, that's the problem. Poor judgment. How many Keurig coffee machines do you need in your house? And I say that with a light spirit, but that is a true story. 5. Okay? Thousands of dollars being spent, Home Shopping Network or Amazon, for things that you don't need. And you're financially tight. The money is tight and we're spending and using our credit card. Or we're giving our information to these spam callers that begin their phone calls promptly at 1 in the afternoon to 4 in the afternoon. And we're giving out our information. It's a problem. Withdrawal from work and social activities. And I've got a different slide on that, but why is your mom or dad, why is your partner stop going to church? Why is the husband or wife now participating and going to the bowling league? Or why have I withdrawn from the VFW? Or whatever is going on. They're pulling back from things. And why is that? And there can be some good reasons. But is it because of cognition? That's the question. Changes in mood and personality. We'll go to the next slide. You can't see this because the print's too small, but this and numerous studies show that at the time of diagnosis, when it becomes very clear that the person is having dementia, what is usually the trigger that kicks off that diagnosis is that mom or dad is seriously, behaviorally not themselves anymore, where they are accusing their loved one of stealing or having an affair. They are maybe seeing things or hearing things. The patient may be the most calm, mild-mannered person in the world and now is boxing and angry and irritable. And before that time, going out 1 year, 2 years, 3 years, social withdrawal, pulling back from church, not going to the VFW, not hanging out with the vets at McDonald's on Wednesday mornings, not playing mahjong and cards or whatever. 3 years out, people stopped going. New onset of depression symptoms in over 50% of older adults, late life depression happening about 2 years out. And then here we are with all these things that are happening 1 and 2 years out after the diagnosis is when our family member is having hallucinations and wandering and pacing and problem behaviors. These studies show us that we make the diagnosis late as doctors and as individuals and families because we're maybe not recognizing or denying these symptoms and problems that we've been seeing going on for the last 2 or 3 years. Or we say, I think this is just normal aging, right? So what is normal? What is mild cognitive impairment and what is dementia? Most important slide, we're videotaping this and I've shared my presentation with Dan Keeley and that can be posted with my permission if you want to share that. But normal aging, you make some bad decisions occasionally. You forget I forgot my doctor's visit today, okay? But your brain's been full because you've had a grandbaby, or there was something that happened in the house, or things are going on. Occasional word finding problems. If you watch me closely, you'll see I have occasional pauses where I'm trying to think of the word. I'll have my little word finding problem. I'm not going to sweat it. Losing something, unable to retrace, performance within expected norms. Meaning you're working, you're being a grandmom, you're being a granddad, you're doing your volunteer work, you're doing the activities and things you enjoy, you're functioning normally. But you have your hiccups. You're not perfect, okay? And that's okay. Mild cognitive impairment, there's a lot to that, but the patient, the family is coming to the doctor saying, something's not right. They're worried. Something's different in me. My brain isn't working the way I want it to. But to do that, we have to do some form of cognitive testing, pen and paper testing. There's no quick, easy brain function scan that we can say, yep, cognitively normal, my little tricorder from Star Trek, doesn't exist. We have to do some form of measurable cognitive assessment, pen and paper testing to kind of see how your brain is working for basic functions. And we're seeing that, there's a problem with testing. Our brain assessment of your function is a little off. But you're still functioning. You're still going to work. Maybe you're having to do some workarounds. Maybe you're using your calendar now. Maybe you're making lists. Maybe you're using GPS to go on long trips and things like that. More complex tasks may be impacted. So they just changed the computer system in your work area, and they've got some new and improved computer program to make your life easier. And you're going, huh? And if you're having trouble with that adjustment, is it the program? Is it you? Is it both? But that's concerning maybe. You're not performing where you want to be or where you were before, and maybe there are some behavioral problems going on. Maybe your behavior and mood is changing, but you're functioning normal, okay? In that situation, I hope you're going to the doctor and having a good assessment done. And maybe it's your untreated sleep apnea. Maybe you're drinking too much alcohol. Maybe you're depressed and anxious and sad because of the death of your spouse or the troubles that your child is having, and it's weighing on you and it's preoccupying your mind. A lot of different things can cause our brains to not work the way we want that are not dementia, okay? Life can cause us to think funny, okay? So you got to visit your doctor to kind of tease through those things, that long list of things that might be at play, and see if those things are going on, and then be followed for this to see if there's a problem. But dementia is that there's Problems with your brain across many domains, meaning language skills, visual interpretation skills, movement skills. Your ability to play the violin or the piano is impacted. You can't play like you used to. It's a decline from your prior level of function. And you're trying to do a workaround, and the workarounds aren't working. And you can't balance the checkbook, and you're a CPA. Okay? And it's not due to psychiatric disorder. It's not because you're depressed. And ideally, we're getting information from the patient, a caregiver and family member, and some form of review and objective assessment for what's going on in the patient. A physical exam, a brain x-ray, blood work. Let's check you over to see if there's anything else that might account for this. And it's really important that we have family members that are kind of informing us. Not that one is right or wrong, but we will see it all the time as doctors. The patient is saying, I am fine, I am Jim Dandy, fine. And the partner is saying, no. And I'm not saying that the partner is right and the patient is wrong, but we kind of have to discern what's going on there. Because our brains often will not allow us to recognize a problem when the problem is staring us right in the face and we don't see it. And it's not blame, it's just the way our computers work. Questions about that? If I can boil it down, dementia is not just a memory problem. It is a functional problem. It's a functional problem. And if your brain is not allowing you to function the way it used to, and it's malfunctioning in these significant, severe ways, we might be looking at dementia. And we need to make sure that we're addressing those other things that may be contributing. The alcohol, the sleep apnea, the diabetes, the stroke that you didn't realize that you had. Those kinds of things. Let's treat what is treatable. Let's stop some of those medicines that are making you swimmy-headed. Okay? This is a restating of it, less words, but it basically, normal aging, hiccups, mild cognitive impairment, you're worried, the testing is off, but you're functioning well. Dementia is the issue of loss of function, and we're seeing evidence by testing and assessment. I love medicine, I hate medicine, I hate medicine at times when we start throwing other words to describe something in a simple fashion. Dementia to me is a simple word, I like it. Several years ago, we started describing dementia as major neurocognitive disorder. Now, what does that mean to you? The doctor said I have major neurocognitive disorder. What's that? The doctor didn't tell you? It's dementia. Oh, okay. I'm making a little light of it, but it's the same thing, we just describe it differently, okay? So your doctor may say things to you, you may want to ask for clarification, okay? Major neurocognitive disorder is also known as dementia. Minor neurocognitive disorder, also known as mild cognitive impairment. We're just trying to make it hard on people, I think. Maybe a difficult slide, but what in many ways you're talking about here is as we age, our cognitive function, the blue line here, our cognitive function is going to go down. It will happen. Many things can keep it high flying and functioning, but it will go down. But there's this time that things are going down, we're asking ourselves, is this aging? Or am I on a trajectory of developing mild cognitive impairment or dementia? And it's really hard to sort out in this, what we call the preclinical phase. All right? Difficult to tease those things out. How many of you are getting things in the mail or on the internet about let's do some blood testing and figure out if you're at risk for dementia? Alzheimer's disease? Are you getting those? Let's raise our hands on that one. Anyone getting, maybe it's just me then. Okay. One of the difficult things about Alzheimer's disease is a breaking down of the brain tissue. We can detect chemicals in blood or in your spinal fluid that detect that breakdown of that brain tissue. Huh, you're saying to yourself, well, I'd kind of like to know about that. Do we really? Because do we have a cure or a fix for Alzheimer's disease? No, we don't. And then what are you going to do with that information? And then what is the insurance company going to do with that information? And I can get negative about this, but we kind of have to be, and it bothers me personally. I'm 61. And if I do a blood test to see if I've got the genetic risk factors or blood biomarkers for amyloid and these other chemicals, how am I going to feel? How am I going to act? How am I going to respond? And then if I have another hiccup, I've got dementia. How am I going to respond? And I deal with this, and I don't know how I'm going to respond if I get that information. And until we get a cure, me personally speaking, these tests have limited role. However, if you've got a very strong family history of your mother and her brothers and sisters and the grandparents before them all had Alzheimer's disease and it kicked in at age 55, I'd think about testing that. Because that potentially changes a lot of things for your children and your life and your understanding of things. That might be a good thing to do. Ultimately, if you're thinking about any kind of blood testing or you hear about that, read about it in the AARP magazine, talk with your doctor and see if that really is the right test for you. These are the different types of dementia. Remember, automobile and cars, Alzheimer's disease, 60 to 80% of dementias. Vascular dementia, those are the individuals that have had some form of stroke, brain injury, that has injured part of their brain that is associated with memory, reasoning, concentration. Lewy body dementia is a specific type of dementia, often related to Parkinson's disease, that with Parkinson's disease, a person will late in the disease develop dementia. And then frontal temporal dementia is where the front brain tissue is shrinking out of proportion to the rest of the brain, causing very specific types of behaviors and presentations of dementia. These other things are uncommon, and ultimately, though, when you go back to those circles I showed you and I'm crossing things off, usually people have multiple causes to their cognitive impairment. The alcohol and Alzheimer's. Alzheimer's and strokes. Strokes and a head injury. It often becomes interconnected. And often it's not just one thing. It's multiple things that have contributed to injury to your brain. Severity and stage. Briefly, watching the time, not talking too much. Mild, the definitions that are used for mild, moderate, and severe. Mild, you've got problems, but you're managing on your own. You only need a little bit of supervision and assistance. Your kids checking in on you. Your spouse just making sure the meds are right. Spouse double checking the checkbook. Just kind of, watching. Mild. Moderate. Your loved one needs help. They need help with driving. They need help with the medication management. They need help with the bill paying. They need help with the cooking and the cleaning and maintenance of the home. Moderate. I call it the helping phase. It is the longest phase, potentially lasting decades. The severe stage is when the person is no longer, in many ways, no longer able, they become in many ways bedbound. No longer able to walk, meaningfully communicate, troubles with chewing and swallowing, nutrition compromise, choking, difficulty with pneumonia, what we call aspiration, skin breakdown, and decline. That severe stage of dementia is the shortest. Upsetting to hear. Upsetting to hear.
Under moderate, what does remembers remote life mean?
Remembers remote life. So you can tell me everything about the Korean War and everything, but what'd you have for breakfast this morning? Or what house are you currently living in that you just moved into 2 years ago? You can remember the past, you're having trouble with the recent. So think of it as in your computer or a library, you have the hard drive, the permanent memory, but the RAM, that quickly accessing memory, that RAM is the problem with dementia. People will remember things about the color of the truck in the front yard of her grandmother's house from 1942. True story from this afternoon. People have that strong remote memory, but what's going on recently, it's not there. These are the protective factors and the risk factors, and the upside of this, too much text and everything, but in short, if you want to reduce your risk of developing Alzheimer's disease, pay attention to these things regarding your lifestyle. Take care of your sleep, exercise, reduce your alcohol consumption, don't smoke, regular exercise, I think I mentioned that. Take care of your medical conditions, eat a healthy diet. 20 to 40% of risk factors related to developing Alzheimer's disease are related to lifestyle. Questions? And I went too long. I wanted to give 30 minutes, but I'll go in the back.
Frank, does a head trauma stay a risk for a long time, or does it have to be proximate for causing dementia?
So, the general question for head trauma, a single isolated remotely or recently, it depends. The person who experienced a remote head trauma with a devastating injury, can't move their arm or leg or personality, functional changes, that inflammation and injury later on in life can predispose and progress to dementia. Head injuries recently, because of falls, accidents, car accidents, trips, injuries, falls, those become additive. If you're bleeding into your brain, that's more not good news. What will happen when people have head injury? The function will decline, there'll be a change, then the person will rehab and recover. But do they recover all the way? That's the question. And often we don't do a good job of assessing cognition after brain injury. You can walk, you're walking now, you can use tools and things like that with your hands after a brain injury, but are we assessing how a person's memory, reasoning, concentration skills? We don't do a good job of that as a country and as a healthcare system. And that's something that we could do better at.
You hear a lot about supplements that you can take to help with memory. Is there anything to those at all?
Okay. Question about supplements and memory. That's a very common question. They will not hurt you. First off, they won't hurt you. They will put money in other people's pockets. And it will make very expensive urine. Okay? And I'm being very blunt with that, but there's no, Prevagen is one that is on the daytime infomercials and things like that. There is no science to that. There are testimonials. Testimonials are not science. And I think you've got, for the cost of those things, take that money and buy a gym membership. Take that money and go to the library. Take that money and go somewhere else and do something with your money.
Not just supplements, but what about a vitamin, a common vitamin, multivitamin, is that good?
Question about multivitamins. There are some studies that suggest it might be beneficial, but not in a way that you'd say, oh, my brain's better. You're not hurting yourself. A reasonable thing to do. Super supplementation with vitamin B12 or other vitamins, not beneficial. There are situations where your doctor will check vitamin levels, and if he's saying to you, you have low vitamin B12 or B6 or whatever, take those supplements. Vitamins are part of the chemicals that make up the tissue of our brain, our muscles, our bones, and those serve as building blocks for those organs to work. So if a doctor identifies a vitamin deficiency, take those specific supplements, and a general once-a-day vitamin is a perfectly reasonable thing to do.
How is dyslexia or epilepsy or ADHD impact?
Great questions. How does epilepsy, ADHD, and a dyslexia potentially impact? The key thing there is those are identified, I'll say, learning difficulties, learning, not necessarily disabilities, because the person has worked around those things and they've learned workarounds or have developed skills to overcome the reading problem or whatever. Those with current knowledge don't necessarily predispose to, I'll talk about epilepsy differently in a minute here, those don't necessarily correlate to a problem because you've developed adaptive solutions to that. If a person with ADHD is no longer able to adapt and function, well, there's something else going on, but it doesn't necessarily make it a high-risk issue. Epilepsy, different story for different people for the causes of epilepsy, lifelong since childhood or developing late life related to strokes, brain tumors, brain resection, etc. It depends. It's not necessarily a risk factor. It's more about what's causing the person to have epilepsy as maybe being a risk factor. Does that make sense?
I have a question on that.
Yes, ma'am.
White matter disease.
White matter
Which has
disease.
been attributed to epilepsy since childhood.
Okay. So have you heard of the term gray matter?
Yes.
And then white matter. So the gray matter are the actual main body of the cells that control our brain. They're the command post of, and then they send off wiring. Literally, they send information through pathways in the brain called white matter. And white matter changes are a type of scar tissue or a rust, if I'll use that word, where the connections are being frayed and not working as well. White matter, if your connections in your house don't work well, you know, like in your electrical system, you're going to get shortages. And your light switch is not going to work, and the ceiling light is going to be flicker and blink. Well, the brain is kind of like that with white matter change. You want the least amount of that as you can, and white matter change is usually related to risk factors of cardiovascular disease. White matter change can be due to a lot of different things, and it's a different matter entirely if a person has had that problem since childhood. And so white matter changes or rust or these short circuits in the wiring of the brain, that can create problems for our function. And white matter disease is impacted by hypertension, diabetes, smoking, the usual things that we tell people that we've got to get under control, cholesterol. I hope that helps.
How would you know if you had white matter?
It's an X-ray finding. It's an X-ray finding of your brain, a brain CT or a brain MRI.
But if you don't have any, I mean, you have to have some symptoms in order to have that.
No. I can have white matter changes in my brain right now. Just from...
So you need to go and say, I'd like a X-ray or whatever of my head.
And if you came to me, I'd say, why do you want to know?
I'd like to know. Well, that's my other question. Did I hear you say, there's really no need to know to have this test or any of the tests if you're functioning? If you're functioning and you think you're okay, you don't, what is the point in knowing?
Okay. So if you think you're okay, and your husband's going, sir, you can sleep at my house tonight. It's a great question. And if a person's saying, it's okay, I'm fine, but tell me about why your car is wrecked. Tell me about why we have the 5 Keurig machines. Tell me about why, and you're saying, well, that's... So the person's ability to diagnose themselves and really be truly self-aware for what's going on we can lack awareness of that. And so then again, it's going back to your doctor and me talking with you and your partner or your children and looking at the story, looking at the issue, doing a basic assessment to include an X-ray of your brain, to include some basic pen and paper testing to see if your basic brain functions of language skills, visual spatial skills, memory skills, just basic skills, not an intelligence test, not an intelligence test. Think of it as a skills test. And if we find that your skills tests are normal, your blood work is normal, your X-ray of your brain is normal for age, and your physical exam is normal, then you're experiencing normal aging.
If I'm not, and you, not me, but should one not? What's the point? Okay, now, I'm not even going to say those words, but an individual might know they have it, then now what?
Peace of mind. I think this gave up on me. Peace of mind. Peace of mind.
For me?
For you and your family. You would have peace of mind that, okay, I've got a problem, and now I should be making, died on me again. All right, I'm going to put on my army voice. It's peace of mind that you have the peace of mind that, okay, I'm going to have an advance directive. I'm going to talk with my children and let them know how I want to live my life. I'm going to modify the house so I can live and die in this house. I am going to move to Shady Acres. I am going to move in with my daughter and take her up on her offer. I am going to meet with my financial advisor to think about redistributing funds. And it gives your family peace of mind that you're letting them into your life for them to help you through that.
I understand. And that makes perfect sense.
And that's why we do it. That's why you should do it. I don't have a pill, shot, or surgery to make it go away. Don't. But there's lots of other care out there that doesn't need an MD doing it. The MD has the power of a pen to do a lot of things, but those other things, that's your court.
Do you have a handout of all these wonderful suggestions that we could share with our families?
I will, alz.org is really good with that.
Basics?
Down to the basics. And the other thing is that Aging in Place Council for doing these other plans. The National Aging in Place Council and AIPC.org. Wonderful resource, the planning guide looks like that. And it helps you and your family, your partners, to make those work around those things. More questions? I can be here all evening. I'm going to go new people.
My doing the New York Times crossword puzzle every day isn't going to help me, right?
Does it bring you joy?
I don't do it. I just want to sound impressive. No, but those kind of mental tests, that doesn't do anything.
I see that all the. That's a really good question. And if it brings you joy, or it brings you with your partner and you enjoy it together, that's what matters. So, true example. I don't do word puzzles and things like that. But then my wife has started doing that. The Washington Post bee, the spelling bee, and some other things, and we do that together. I love that. But to sit down with a crossword puzzle, So, but to do cognitively engaging things, coming to meetings, library, faith groups, clubs, organizations, picking up the guitar and learning to play music or whatever, cognitive stimulation. Sorry, that's okay. You're okay. Cognitive stimulation, that feeds your brain. If you want to feed your brain, you need two other organs to do it. Hearing aids. Let's talk about this. So, if you're over 60, you're going to get cataracts. Okay? And if I asked you to raise your hands, I would bet, looking at the audience here, probably 60% or more have had cataract extraction. Would you have left the house today without your glasses? Probably not. All right? Take care of your eyes. Your vision connects you with things. Helen Keller said that. Helen Keller also said your hearing connects you with people. The most common age, and we just published an article on this, the most common age for first-time use of hearing aids, 80 years old. 80. How long has that average individual been having hearing problems for? 10 years. And hearing loss is strongly associated with developing cognitive impairment. And what holds us back is Medicare will not pay for a hearing exam for hearing loss. Medicare will pay for a hearing exam if you're having memory problems and may be related to hearing loss.
So then you tell them you have memory problems.
I didn't say that. The second thing that has changed, the AARP website has some wonderful resources for this, is the over-the-counter hearing aid. The other thing that holds us back is that prescription hearing aids can run into the thousands of dollars for two, all right? And depending on the bells and whistles and things that you put in your hearing aids, up to $6,000. Over-the-counter hearing aids, and again, there's a price range with that, anywhere from $300 to a couple $1,000s with bells and whistles, you get equally effective hearing. So research it, maybe get a hearing testing done. You can get apps on your phone to do your own in-home hearing testing. Research behind that shows that it is equally effective as in-office testing. The program that I use is called Mini, a mini hearing app, and you can basically put in headphones or earbuds and do that tone testing. And if you've got a problem, research it. Look into it.
That M-I-N-I?
Mini, yep.
Okay, thanks.
Sir?
Okay, I have a question. Well, it's not a question, it's an answer that was given to me.
Okay.
Like, for instance, when a doctor wants to prescribe medication for you, and you have good health insurance, the strength of the medication that the doctor wants to prescribe maybe is half a pill instead of a full pill.
Right.
So you go to your insurance company, have a discussion with your doctor, and you say, will you prescribe half a tablet for me for this medication? Most insurances, if you have good insurance, will, with a discussion with your doctor,
Yes, sir.
prescribe medication that you don't need a full pill, but your insurance company will pay for medication that instead of you having to buy it over the counter,
Right.
if you have good insurance, will pay for your medication at a nice price.
One of the things that I think I can say for doctors, we see an indication, we have a good medication to address that issue. For us, 1 + 1 = 2. Here's the medicine, and let's see how it works. But what is lost on us, cost of that medicine. Is that medicine tolerable? Can you cut it? Will the insurance pay for it? All those kinds of things. The doctor's like, I don't know. And I'm not knocking doctors for that. It's just everyone is so different with, I think there are like, I don't know, close to 100 or more Medicare Advantage programs in Virginia. I won't be able to keep up with that. So when you get those medication questions, come back to the doctor's office, talk with the nurse, talk with someone in the office. Can we get this at a lower cost? Do you have some form of medication program where I can apply, fill out a form, and get the medication at 1/10 the cost? Work with that, because to me it's just outrageous that a medicine will cost $2,000 a month. And work with your doctor's office to try to work around that. Pharmacists are also a wonderful resource that they write to this, company, fill out this form, and they'll find a break for that. Why that break isn't given up front, don't get me started. Sir?
Difference between a primary care physician and a geriatric physician. And when should there be a transition at some point in time, or?
I'm heading for the door. The number of geriatricians, doctors like me, that focus on the care of older adults will be half the number it is now in 2030. Having a geriatric primary care doctor, a geriatrician, a trained doctor that has done internal medicine, family medicine, plus fellowship training in the art and science of taking care of older adults, the number is getting smaller and smaller. We're a dying breed, and that's the facts. It's not. Same story for geriatric psychiatry, same story for neurology. The number of available neurologists is declining. So the most important doctor in your life is the primary care doctor, and caring for people with dementia. For the vast majority of patients who have dementia, it is a primary care diagnosis and a primary care issue to address and work with. The primary care doctor should be contacting the geriatrician or the neurologist for help. This seems a little strange, or this is off, or what do you think about this, or trying that? Let's do that. But for seeing a geriatrician to become your primary care doctor, ain't gonna happen. Or you get lucky. How many of you have experienced ageism? Ageism. Raise your hand on this one. Ageism. How many of you felt that you have something in a doctor's office, medical care, Starbucks, Kroger? How many of you felt that you were, in a way, discriminated against or judged because of your age and hair color? Okay? So I think part of this issue of why don't we have more geriatricians and things like that is I feel that we we do not embrace the care of older adults the way we should. So that's my 2 cents.
That what you just said is correct.
Are there
Because
certain diets that would help people with dementia?
Are there diets that help people with dementia?
Well, slow it down or whatever.
The best evidence for preventing dementia in the first place, what is called the Mediterranean diet. Best information, again, Alzheimer's website. The best diet for a person who has dementia is the diet that the patient will eat. And so your dad, your mom has never eaten olives or cooked anything in olive oil in her lifetime is not probably going to be happy about this whole Mediterranean diet thing you're talking about, all right? And so with dementia, the senses of sweet become really elevated, and nutritional compromise becomes an issue, and texture becomes an issue. And frankly, in a person who has Alzheimer's disease or any other dementia, I just want them to eat. Now, I'd like them to eat healthy. And can we do things by protein supplements and food prep to help get healthier foods into an individual? Yes. But I just want the person to eat. And getting a person to change their diet to something they've never eaten before, it will just, it will.
with that, if you invite somebody over to your house to eat food, you don't have to tell them how you made it. Or you get them to eat it,
Yeah.
and then ask.
Yeah, you want to avoid that clashing. Mom, you gotta eat, and I don't like this stuff. I want biscuits and gravy. All right, let's go.
Well, then what you do is you buy the stuff to make your biscuits and gravy that they will enjoy, and you, just like you did when you had your children,
Yep.
and you were raising them, and
Yep.
you said, try it, you'll like it.
I'm going to look for some new hands, and I'm going to come back for some people who have raised their, any new hands, ma'am?
Yeah, well, I'm in a family of 10, there's 10 children in the family. My mom's side of, my mom and her sister both died of Alzheimer's. But she was 90,
Okay.
My dad's side are living into their hundreds. Half of my brothers and sisters are totally paranoid about getting Alzheimer's.
Yeah.
But the ones that are married with lots of children, they don't have time to even think about it. If that's your, I would look at the risk factors. If that's my only risk factor, I mean.
Yeah, and that's the problem with the blood tests and the genetic testing, because there are so many other factors that determine whether or not a person is going to develop any kind of dementia. So if you have no genetic risk factors for dementia, but then you have smoked, abused drugs, alcohol, head injuries, uncontrolled medical problems, that person's going to get dementia. Person who has had good lifestyle, healthy lifestyle, has some genetic risk factors, but many other protective factors like lifelong learning, healthy diet, exercise, physically fit, that person is likely to die from something else and not Alzheimer's. The type of Alzheimer's, when we step back, we're all going to die from something. We all die from something. Surprise, alert. Alzheimer's disease is typically a late life disease. Less than 10%, closer to 5%, is early onset disease, 65 and younger. Most of the time, it's a late life disease. People in their 80s. With late life Alzheimer's disease, depending on risk factors, lots of factors there, that person will live with that diagnosis 5 to 7 years and then die. And you say to yourself, well, we all die from something, whether it's stroke or heart attack or cancer or something. that is the brain tissue wearing down to death. And so that late life Alzheimer's, really late in life, the 90-year-old person, that, I'm not, please understand my heart with this, that is in some ways understandable. It's a different issue. You're 70, and the grandbabies are coming, and you've got travel, and you've got things to do and places to go and art to art, and it's a different issue at that juncture in time. And that it's the same disease, but different disease. And so we can't pigeonhole that. So I'm not really answering your question, but genetic factors, genetic predisposition, having genes for Alzheimer's doesn't mean you're going to get Alzheimer's. It's a risk factor, and it does not predict you will or will not. But if you've got the high-risk genes and you start doing these things that I'm talking about today, that's a very different conversation.
I'm sure a lot of us in this room have noticed hindsight's 2020. And you know a person that has developed into a cognitive problem that's gone beyond them taking care of themselves. And you look back and you say, I should have seen that coming because she or he did such and such, used to hide things, or anxiety. Oh, this person was very anxious all the time.
Yep.
I can remember this person. And then you say to yourself, I should have seen that coming.
Be kind to yourself. No, I mean that. You don't know. Love makes us see things differently. We want to support. We may feel that we're ill-equipped to approach it. We may feel like we're judging a patient. A dementia diagnosis feels like a judgment, and that's unsettling. And I think in that situation, be kind to yourself and let that go. You shouldn't carry that. And your thought, what you said to us was beautiful and powerful, and for what it's worth, correct. We have those regrets. You're absolutely right.
For those of us who have macular degeneration and have trouble driving at night, may we be excused.
Here's your hall pass. And thank you, Brian. And can I that kind of awareness? Yeah, that's what it's about. Thank you, sir.
Thank you.
Oh.
Do you deal with deterioration of the body? I mean, a lot of these things can be deterioration of the body, and antisocialism, and you're just not able, you're too tired to go out, you're...
So do I deal with it? Yes. Do we all deal with it? Yes. Geriatric doctors deal with that, but again, I think it's that primary care doctor that can hope, if you've had a long-term relationship with your primary care doctor and it's a good one, and they know you and they know your story and they know about your arthritis and your hip replacement and the family issues and things like that, that person that is ideal in guiding that, and there can and should be times that the doctor should refer for things that seem strange or out of the ordinary, or a second opinion, of what's going on. And those are reasonable things to do. But our bodies are wearing down, our brain wears down. And that's in many ways what dementia is. Your brain ages along with your bones. It just does it differently. Your muscles age and your brain ages. Your eyes age and your brain ages. And that's what dementia in many ways is. New person, I'm new, yes ma'am.
Okay, if a person is into mild memory problems, does that indicate that the next step is going to move on, or can you just stay into mild memory?
Great question. Question is, if I have mild cognitive impairment, does that predict I'm going to go into dementia, or am I going to stay there, or is it possible I get better? All three. If your mild cognitive impairment is due to a recent illness, a medication you're taking, depression, anxiety, an untreated medical condition that you're treated and you get better, ching. Can you stay there? Absolutely. Can you worsen? Yes, you can.
It's not a sign.
It's not a sign necessarily. Should it be monitored and watched like we do with your blood pressure? Absolutely. And so some form of pen and paper cognitive assessment, maybe on a yearly basis, turning to a family member, how's she doing? Mom's good. Or, no, mom's having trouble. And that helps us sort it out. But it does not condemn you for progression. Will we worry about it? You betcha. You're worrying about it, we'll worry about it too. Yes, ma'am.
We usually associate Alzheimer's, dementia with the elderly.
Mm-hmm.
But there are people that we know that have had it at 50 years old.
Mm-hmm.
Is it predetermined at some point? Are you predetermined to get it? Is it predestined?
That ties into the genetic risk factors. There's people who have, for example, Down syndrome. They are predisposed to developing Alzheimer's disease. So that kind of points to the genetic factor. There are a grouping of genes. They're called alleles. ApoE is the term for them. And if you have 4 for 4 of the bad genes, your risk goes up, and your risk of developing early onset disease goes up. So if by predetermined, do you mean is there a genetic risk for people who have that early onset disease? Yes.
Your comments on the role of newer FDA-approved agents in treating Alzheimer's.
There are new agents that have been approved by the FDA and Center for Medicare and Medicare Services, where after a detailed medical assessment to include brain MRI testing, looking at the brain tissue, probably some blood testing to look for genetic and biomarkers, to infuse, basically inject medicines into your vein to bind some of the chemicals that are possibly created from Alzheimer's disease alone, not not from strokes, not from Parkinson's disease, only Alzheimer's disease. It has to be a rock-solid diagnosis of Alzheimer's disease. We can infuse this medicine into your veins to try to clear out this chemical called amyloid. And the pharmaceutical companies tell us that it slows down tests. It slows down the decline in tests of cognitive function. People who got placebo, the sugar solution, declined. People who got the active real medicine declined also. The people who got the real medicine declined less than the people that got the sugar pill. The problem is with these medicines is that the medicines, you would not recognize that your loved one has benefited from it. And 20% of people receiving these infusions develop brain bleeding or brain swelling that then has to be monitored, needs to go away before you resume therapy. The cost is also $28,000 a year just for the medicines itself. I I am not in favor of these medicines in any way, shape, or form. And I can show you the draft editorial I've got, okay, about this. It doesn't help us. It doesn't help us for the things that we need, which is the caring and the preparation and the planning and the social supports and all those things that help us live our lives. These medicines do not give us what we want. We want our mom and dad back, balancing the checkbook, driving the car, going to church, living their lives. These medicines will not do that. And so I'm steadfastly opposed to them.
Is it medicine Aduhelm?
Aduhelm, and the other one is lecanemab. Aduhelm has been taken off the market because of its brain bleed problem was 30% of patients. I think we will get to a point in time where we will have medicines that meaningfully benefit, but my opinion is that we are not now.
Something kind of random, just free ice baths, all kinds of things, because it stimulates the brain, everything.
Free ice baths?
Cold water, using cold water, maybe not ice, but as opposed to, some people like to come out of the shower looking like a lobster.
Yep.
Which I think it's just cold.
The ice bath, there was a good podcast on Hidden Brain, that it's a mindfulness exercise. Because you're in an ice bath, all you can think about is how cold you are. and it's a mindfulness exercise. Will it help? Does it prevent dementia? No, but it is a mindfulness exercise. Yeah. I wouldn't sign up for that one for dementia though. It'll slow your heart rate down, and that causes a whole other layer of things. We can keep doing questions. We can call it. I'll stick around for more questions if you have it. It's 8 o'clock. Other questions, group, and thanks for listening. Thank you for having me. Thank you for having me.
Awesome.
Oh, thank you.
That was absolutely amazing. I have so much